The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The opinions and ideas expressed are those of the hosts and guests and do not necessarily represent the views and opinions of any organizations we may be affiliated with. As always, follow your local protocols. Hello, listeners. If you only knew what's going on right now, welcome to the Triple M Podcast. We are so happy to have you tuning in and listening to us. Just fair warning, totally unscripted hazing session for our illustrious med student, soon-to-be Dr. Regan Washist. She's sitting here laughing because we're basically, Doc, I think he has a scenario that's just great cognitive load. We're going to be talking about hypothermia today. It's cold. It's cold outside. It's negative 25 real field temperature here in Chicago. And I'm sure colder where you guys are sitting. Hello, Dr. Collins. How are you, sir?
What a wonderful time to talk about hypothermia. And what better final exam for Regan before she becomes Dr. Regan than to put her in the hot seat again and talk about hypothermia.
An exam she didn't know about. She didn't know what was happening.
Welcome to residency. There will always be exams you didn't know about.
Honestly, this is the feeling of being a student. It just feels like every day you show up and it's just a gnarly exam and you don't know how you're going to do, but you try because that's how you learn. But this is a very fitting topic because it is currently like negative 32 where I live. So yes, hypothermia, very relevant.
We apologize, everybody. We should have gotten to this like kind of before it got cold, but all of us have been flung around the world and our schedules, but we're happy you're joining us today. So let's get right into it. Doc, you have a scenario for us. What do you have?
I live out in the middle of rural Minnesota, and we got a lot of lakes. We got people that like to fish, that like to set up their little ice huts or their ice castles. You know, there's some really elaborate looking structures, but we'll fast forward a little bit. We'll say it's getting into like March, April. The ice is beginning to thaw a little bit, and there's just one real avid fisherman that wants to get one last good fish in before he brings the trailer off. Regan is hanging out at the local EMS agency, and her partner, Phil, is hanging out. They're having a good time talking about stuff that they've seen on their various adventures and traveling to different facilities. And the page goes out that there is an ice house submerged in the lake. Law enforcement is on scene. The tow truck is coming to try to get this thing fished out. And that's what you got.
As most EMTs are going to really be thinking in their head from their training, BSI, scene safe. Like, I cannot remember how many times I had to say that in our training. And this is a really good case of that too, because you have this ice house. I feel like we've all seen some sort of issue happen in the ice fishing world, but you see someone struggling in an area that is probably unsafe for you too. You want to make sure that you're not becoming a patient. So of course, first and foremost, you're not just jumping into this water and grabbing this patient out because you're probably not coming out either. So like you said, Doc, tow truck is coming. You have police on scene. You probably have fire there too. Like, know who's with you and know who's the best resource to get these things rolling.
So you roll up on scene. Tow truck is already there. Fortunately, they were like driving by to go get a coffee at the local coffee shop. So they were just in close proximity. Get the hook in the water, get that truck pulled in with the trailer on top of it, and they break into that building. And fortunately, the person is inside that building. So you're able to extract them. And what do you find? What do you find in that trailer? You find a single 65-year-old gentleman, probably a retiree, just spending his life out on the ice. And he is cold and he is blue.
So like any first patient you see, you get that general assessment going. In these kind of cases, it's hard not to just pause and kind of panic a little bit because this is not just a normal individual that you're seeing in front of you. But again, everything is just kind of stepwise as you're running through this. See if you have a pulse. See if this patient is breathing. Start with those ABCs and see what's going on there.
All right, so let's do what we've done every time for these scenarios. Let's walk through things. But what's the one thing that we should be thinking about in this particular exception? The nice thing is you've got two people here, right? Maybe Phil's grabbing the stuff, but there's two of you. what's the primary concern for someone that's been submerged underwater?
I mean, patient has been drowning and you know that they are in a cold water submersion. So they're going to be not only freezing, possibly frozen in there, they're going to probably have some water in their lungs. They probably might not even have a pulse at this point, depending on how long this ice house has been under. Yes, the tow truck was just on the way to get coffee, but who knows how long it took to actually get them out in that process.
So let's just say, for the sake of argument, you start checking your airway, not breathing, not spontaneous. And while you're starting to yell at Phil to get the equipment ready, they're also pulseless. Where do you start?
So a lot of times in these patients, you want to kind of jump in with any sort of measures that you know. You have a pulseless patient that's not breathing. This is going into like an ACLS protocol here, or BLS, depending on who's actually on your rig. But the thing is you have this whole other case of hypothermia. Likely, I mean, we haven't taken this patient's temperature yet, but let's use some of our common sense here. And that almost creates, how I think of it, as like a time buffer, because there's that old saying is, you're not dead until you're warm and dead. Our patient right now is in that cold setting. You have some time in there, but that doesn't mean that all of these other interventions can just be paused forever.
Phil, your partner, Regan, looks at you and says he's pulseless. What is your first response? And we'll say, for the sake of argument, that you are two paramedics today, because in my shop, sometimes I got two paramedics running together and they have a great time, and they tend to just cause a ruckus when they're together. It's a fact of life.
Yeah, so Reagan yells over at me and says, hey, listen, this guy's pulseless. Immediately accounting for safety and an environment that like we can actually stay for a little bit. I want to get on that chest. I feel like that's the priority for me. Get the compressions going and make sure that that is a continuous piece of our intervention. I am now committed to good, effective chest compressions, allowing for recoil and making sure that I'm focused on quality of chest compressions. I also, anytime I get on the chest, I like to start looking around for who's going to take over the next couple minutes. I know for a fact, whether or not I feel it, the quality of my chest compressions is going to decrease over the course of a few minutes, particularly in a challenging environmental condition. And if there's literally anybody else around, I can in 3 seconds go, look what I am doing. You are going to do the same exact thing. Get right down on the floor next to me or on across from me. In a couple minutes, we're going to switch. I want you to pay attention to how fast I'm doing this. And I can say all that while doing compressions. And we're simultaneously, as we often do in the field, getting stuff ready. You're always doing 3 or 4 things at the same time. So if I can get 2 or 3 compressors ready to go, hey, listen, you're going to have a job in the next 4 minutes. Are you willing to help? And they come over near me and like, how can I help? That's where my mind is. So now focused on compressions, good compressions, correct pacing, good recoil for the chest, and I have some backup in the next couple minutes so that we have a complete cycle.
And I think it's important to remember, too, that for the layperson that hasn't done it before, there are various songs and rhythms that we can provide for them just to kind of help them keep their pace up. And as much as I hate to say this, my wife just showed me a video the other day. Like, like how they show the videos on social media about staying alive and like the other songs for chest compressions. Apparently, the Pink Pony Club has the appropriate chest compressions, which depressed me immensely because I think that song is utterly ridiculous. But great, now I've forever stuck in my head that you just got to start singing the Pink Pony Club while you're doing chest compressions.
Whatever gets the job done.
That's true. Okay, so CPR in progress. We're probably going to get an adjunct setup of some kind, but at the same time, we've got other things that we're worried about. Reagan, walk us through the remainder of our ABCDEs. Walk us through the timeline in terms of getting our patient from point A to point B, B being our hospital.
So, of course, taking care of those ABC, D, and E's first, I would say. So we have someone on the chest. If we could just get an adjunct in there as well, we don't need to be jumping very quickly to an intubation. Yes, having airway protection is great, and those adjuncts or even the supraglottic airways can work really well, especially in these more austere environments. I mean, we're thinking we're out on this lake. We might not have all the equipment near us. We might not have enough people to go with that intubation. So getting that airway protected, keeping someone on the chest, or having even the Lucas device brought out if we do have one on the rig, and getting set up with the monitors, again, if they're out there, because of course we got to get everything set up as best we can. But the best thing that we can do for a patient is to get them into that hospital with that more definitive care. However, there's a nice balance between working in the field for a bit and coordinating that transfer. And I'm just thinking, if we're out on the ice here, I don't really want to have that stretcher rolling around, at least with one person. I think you're going to cause a little bit more problems than you are just getting it out there, but that's coming with that coordination. And just like how Phil talked about, you're going to be doing multiple things at once. Someone can be compressing and someone can be getting this supraglottic airway while we're coordinating with fire. Hey, we're going to need a way to get them out of here. So having that conversation going and knowing kind of what your next step is, and at least getting that safe evacuation for that patient after we've had a nice airway secured, we have at least a plan for who is continuing on the chest or having a mechanical device doing it. And if we can get set up with those monitors, because if for some reason we find a good shockable rhythm, that's where we want to go to next.
Yeah. So let's recap here. Airway, you got the iGel in place. We're not going to muck around with the CMAC or anything like that because time is brain and we got to keep moving here to keep the oxygen flowing. But good CPR. We get hounded about this in BLS because good CPR saves lives. I remember we sat through a talk by my colleague, Dr. Josh Stilley at NASP, and that was like his big thing is that if you don't have good BLS, then the rest of it's kind of a moot point. Airways protected. Breath sounds, you listen around a little bit, things are rattling around in there and crackly. So probably some concerns of some form of aspiration occurring from going under. Circulation, pulseless currently as we're doing CPR. Disability, irrelevant right now because the GCS is 3. But this gets to the most important letter of our primary survey before we jump into pathophys, and that is E. Let's unpack that a little bit. Let's go have Phil talk a little bit about it, then Regan can jump in and give her thoughts as well.
Yeah, so up until this point, been on the chest. I now have somebody who's maybe taken over for me, and I'm satisfied with their plan. They're doing good chest compressions, or we have the Lucas on. Now we have the airway secured. The next thing that I'm thinking about is let's get this person out of here. Just from a logistics standpoint, make sure that if you're on scene and you have a fire company or rescue personnel with you, identify who is in charge. That's super critical for making sure that communication to all the teams is as streamlined as possible. So for the fire company, I'm looking for whoever the officer is, right? Whoever the lieutenant, usually the front passenger seat person, or if it's a rescue company or the police, somebody with stripes, this is why knowing who you work with is so critical, because instead of saying, hey, you, or hey, Sarge, I know that it's Daryl, because Daryl and I have actually introduced ourselves before any of this is ever needed. So that's huge. Okay. This is definitely a Stokes basket situation. Totally agree with Reagan. I don't want to be dealing with the stretcher out on the ice, slippery conditions. Best case scenario, you potentially slip and create a huge mess. So this is a rescue Stokes basket situation. I want this person in an actively warming ambulance as quickly as possible and out of the conditions that they are in, because we're not helping them by not removing them from the environment. And here's that E. The next thing that I want to focus on, while I'm also making sure that compressions and airway and things are being managed on that end, is that all that wet clothing has to come off. Here's a logistics pearl for you. You're going to get some folks that are super excited that are going to pull out some trauma shears, and they're going to want to cut through down coats. And I got to tell you, if you can avoid it, really, really try and not create a giant mess while you're aspirating down, floating all over your ambulance. I mean, it's just terrible. So as best you can, try and avoid cutting through down coats where you're just going to get a bunch of stuff all over the ambulance. But they do need to get out of all that wet clothing. They need to get down to nothing, because all that wet clothing is doing is sapping what little heat is left. Anything you're doing rewarming wise is going to be negated by the fact that they're wearing ice cold clothing. So all that stuff needs to come off. You need immediately dry blankets and sheets and everything as best you can. Anything touching their skin needs to be dry and helping for the warming process.
With that warming process, and Phil, you kind of mentioned it, but it's a point that I want to make is when you're going into the back of your rig and you're grabbing your equipment to go out to where the patient is, take the extra 2 seconds and crank the heat in the back of the ambulance. Like, do not wait to do that until you're bringing the patient back in there, because it takes a second. It really does. And this goes for the reverse when you're, in the summer and you're going to have this patient who is just hyperthermic. You want to just crank that AC on there. And having that in mind, like bringing it along with your bag checks, like you got your first in bag, you're bringing the monitor if you need, cranking that heat up. Because once you get this patient back in there, and whether you're bringing some blankets to remove clothes out in the field and getting those dry blankets on, or wait until you get into that back of the rig where you have a little bit more protection, you don't want it to just be warming up back there. And granted, it's probably going to be warmer than the frozen lake they've just come out of, but it helps to get that rewarming going. And the other point that we need to make here is it's not like you need a blanket warmer in the back of your ambulance. That temperature difference does mean something. Like, they are coming out of a frozen lake. You just have dry blankets that have been in your normal temperature ambulance. Those are still going to work. Don't just avoid those because you don't have these warm blankets. And we'll talk about this with like fluids too. Room temperature fluids are going to be a lot better than having something that would be warmed. And of course, not going with the cold there, but just remember that difference in temperature is really important.
And use your resources to your advantage, right? There's a high probability that Highway Patrol or the Sheriff's Department probably has a space blanket or something. Like, you don't need to just be restrained to what you have in your own vehicle. If they've got a way to help aggressively rewarm this patient or add additional heat to the patient, totally fine at this point. Keep in mind that the main goal of our podcast is we're talking to the folks in the austere and the rural. And so we don't have the luxury, for some places, don't have a bear hugger. So that maybe all they have is some blankets and some saran wrap. Like, get creative in terms of just ways to help trap body heat until you can get them from point A to point B. We've talked about the A's through the E's. Obviously, this is a little bit of a dumpster fire of a scenario, but sometimes these fall through the ices can be quite terrible. And that's why I'm setting it up this way, because it's very high probability that there'll be one somewhere in Minnesota this year. There almost always is. And then you potentially throw in some carbon monoxide poisoning for good measure. And I won't do that to you guys in this particular scenario because that would be mean. And that's a different topic altogether. But let's take a step back. Let's talk about pathophysiology of what the body is doing in terms of trying to compensate and trying to function in the context of somebody's body temp being way below what it should be. Regan, give us a little bit of knowledge as far as the underlying pathophys of hypothermia.
So like a lot of factors in our body, it has a nice set point or a nice range that we like to keep ourselves at. And temperature is no different in there. We have a spot in our brain that is a control of temperature, and we have a range between 36.5 and 37.5 Celsius. So that'd be like 97 to 99 Fahrenheit. And that's where our body likes to be. But if we get into these scenarios and going even as extreme as falling into a frozen lake, our body might not be able to compensate for that. And there's other instances that can cause these changes where our body can't actually correct that temperature imbalance. And there's kind of like 4 different ways that we can lose heat. So things like evaporation, you have fluid on your skin, like when we're sweating while we're working out, that's releasing some heat. In the case like this, that wet clothing can help with that evaporation of heat loss, but that's not what we want. That's like counterproductive to taking care of our patient. Another way that this can happen is through conduction. So this is really like when you have a person lying on a cold surface. So let's say we actually decided to undress this patient and then they're just sitting on the ice. Well, the heat from their body is going to the ice. That's not helpful either. Another way that this can go is through convection. So heat can kind of go out into the air, like if we have an air-conditioned room. But the counterpoint on that is if we have that ambulance temperature a little bit up, we can kind of reverse that, bring some heat back to our patient. And then the other way is through radiation. This can be a little bit more of like a transfer of heat in a vacuum and the whole science behind it and everything. But the point being is that there's multiple different ways that we can have hypothermia within our bodies and that we can't actually correct this. And these usually go to the extremes. Now, if we're not talking like winter weather or freezing there's also just cases of your brain not being able to monitor it. Like if there's drug-induced things, if there's substance use, if it's an increasing age, psychiatric disorders, but these are all kind of out there. Focusing in on our case, usually when you hit a certain point, your body tries to start conserving heat through things like vasoconstriction or shivering. And if we hit a certain temperature, like falling into a frozen lake, these aren't happening anymore. And that is when we need that extra help from somebody outside of us with that passive or active rewarming, like we've started talking about within this case.
The other thing that we really need to take into account is the whole process within the human body at a cellular level. We talk about the pH a lot when it comes to like DKA. If a patient gets more acidotic and it exceeds what the human body is capable of, the proteins of the human body degrade or they become dysfunctional. This concept is the same when it comes to the body getting too cold. If the body is not operating at its optimal temperature range, things are going to freeze, things are going to slow down, things are not going to work the way they're supposed to. This is part of the reason why, when we talk about stuff here further, is why we want to get the patient warm before we start thinking about things like epinephrine or other interventions, because if the body is not in its optimal state, in its optimal functioning capacity, things are just going to float in the blood and not do anything until we get that body back to the temp that it belongs.
Something that's really triggered by this colder temperature that doesn't affect well is the heart. Like cardiac output is one of the first things to drop in there because those cardiac cells do not work well if they're not under a good temperature. And that goes directly with having drugs put in. They're not going to be circulated around. You're just going to inject this drug and it's going to be just sitting in these vessels doing nothing because it's not properly circulated around there. Heat is so important for the human body.
Yeah. So just a couple logistical pieces. So for my BLS crews and my first responder crews, don't be surprised. And Regan mentioned this, the vasoconstriction, right? Don't be surprised that, like, one of the first things you have access to, let's say you're near an arm and I know how to take a pulse, and you reach down for a radial pulse and don't feel one. Obviously, in this patient, we were doing compressions. We're not going to feel anything, but let's dial back from the scenario just for a second. So you had somebody that's like mild or moderately hypothermic. You may also not be able to get a really good pulse because they're peripherally, so arms and legs vasoconstricted. You may not be able to, if you're one of the ALS crews or if you have access to a cardiac monitor, be able to get a really reliable O2 saturation off of the fingers. Remember, that's the most distal, the furthest little piece of circulation that's happening where those probes are. And you may not get a reading, and you may be looking at your monitor going like, well, where is this? And that's when you really have to go back and rely on your basics. Is this person talking to me? Are they able to answer basic questions? Can they tell me their name? Can they tell me anything? Going back to our scenario, obviously this person is out of it and we are doing compressions and so forth. Remember, as you remove all of this clothing, you want to, as Regan said, go back to, let's start covering them up. Let's get warming packs going. Let's get whatever we can to sort of assist that process of rewarming going. And your warming pack locations, remember, armpits, the carotid, so up near the front of the neck, the groin area, all of these places where we have vasculature, arteries and veins that come close to the surface of the skin that we're able to essentially kind of run by a heated source. And that's critical. The more, the better. And again, for you folks that may be running not 15 calls a day, one or two, this is why stocking your ambulance and checking it and not just assuming that everything's perfect from the day before is so critical. Take a look outside, look at your environment and go, maybe we should throw 3 or 4 extra packs of quick heat packs on. Maybe we should throw some additional blankets on. Hey, does anybody have any of those space blankets? They're super cheap. Let's throw a couple of those and make sure we know where they're at on the rig. So that if, for instance, we got out to the ice and we're like, you know what? We need X. We could send somebody to our ambulance and we know exactly where that is. So there's your challenge. Could you accurately describe where a piece of equipment is so that if you had to send a bystander to go get it, you'd be able to tell them? A thing I've run into, and something they don't train you in class, but definitely something that can be super helpful if and when it happens.
So we now know what's broken. How do we fix it, Regan?
So we've kind of started talking about this as we were running through the case, but to keep it like as simple as possible, first stop the problem. If they are cold, covered in cold clothing, get them out of it. Get them into warmer clothing. If they are sitting out on the ice, maybe we get into the nice warm rig. Like these are just kind of the simple steps that we can take right away to stop the offending agent, to stop the problem dead in its tracks there. But the other thing is we don't want to worsen things that are already happening. And this kind of comes along with what Phil was just saying. Yes, we want to get those warm packs on there. But as we're putting those warm packs on there, let's remember to cover them back up and make sure that we're not causing some more hypothermia to them. Yes, the rig's going to be really hot in the back. You're probably going to be sweating, but let's just keep it nice and warm for that patient. It's probably not that long to the hospital anyway, or if it is, you'll be able to survive a little bit of the heat and it's better for that patient. But the other factor of that is that these patients don't have a good ability to protect themselves. We've talked about that vasoconstriction. We've talked about that kind of decreased cellular ability. So excessively moving their arms around or trying to readjust how they are laying can cause more problems because they aren't able to fully protect themselves. Their cells aren't the strongest because they require that heat to function properly. So doing the best that you can when getting these monitors on them to not move them as much as possible, especially these patients that are really, really hypothermic or near frozen. You don't want to force the movement with them. The other thing would be is just starting to get some accurate readings when you're in the ambulance, whether you can figure out what temperature they're at. Most of the time, the temporal thermometers are not going to work really great in these scenarios. If you are able to take a central temperature, this would be things like a rectal temperature, just to know where this starting point is. And it helps with that rewarming as you get over to the hospital. And in our case like this, we also have to remember that we're in this cardiac arrest scenario. We need to continue doing all of those ACLS measures. That doesn't stop because we have these other factors in here. But you also need to keep in mind that along with that ACLS, you don't want to cause them to be getting colder. You don't want to be overly manipulating them. You just want to protect them as best you can because they can't really protect themselves.
So we've talked about what to do. We've talked about important things to identify when you're on the scene. Is there anything out there in recent time, Regan, in terms of literature, research? Like what are the current guidelines or recommendations when it comes to keeping the patient warm or trying to get them to begin the thawing process? Like where are we at in terms of the pre-hospital setting?
A lot of the research, at least that I was running into, were things that were pretty fancy. And while it works really, really well, like things having a bear hugger, having like the vapor barriers, having the ability to even just the heated blankets in an ambulance, those are all great things to have. But when we look at the reality of rural services, this is probably not going to be accessible. And that is okay. You can still provide great patient care without the most cutting edge, pushing the limit equipment that a lot of these bigger cities might have. So like we've talked about, anything that is warmer than what the patient is going to be helpful to them. Sure, if you have a bear hugger, sure, if you have the nice space blankets, sure, if you have means to keep a bath at a proper temperature and start the rewarming dunk in the field, great. If you don't, that is absolutely okay. You're just going to continue to take care of that patient as best you can. Continue to putting dry and warm things on them and getting them into those hospitals where they might have more of those resources.
That's an excellent point, Reagan, you bring up. There are a bunch of fancy things that you can do. Some of the stuff that maybe the medics and the EMTs and the first responders in the field don't often hear about are things like bladder lavage and chest tubes that can cycle in warmed fluids into these spaces and all of these things that the hospital is going to maybe try if they have access to it. But the core lesson there for us is while we're doing all of these interventions, we have this person in the back of the ambulance, get somebody on the phone or the radio and make sure that the facility you're planning on going to has a heads up that this is happening so that they can get all of these things together. Simple. On the hospital side, we may have a night where it's full of people. So we need to clear a room and clean it. We need to get the bear hugger, which is essentially like an inflatable blanket that blows hot air. We need to get that ready. We might need to get a warm water circulation mat that sandwiches the people between two warm, big gel water circulating pieces. That's another machine that can be used. Some of these more invasive bladder lavage, chest tube type things, all those require kits and special equipment and the right personnel and enough personnel to be able to be ready to do it and do it quickly to give this person the best chance of any of that working. What it comes down to is make sure that some point, particularly if you have a shorter transport, I know that's not necessarily the case for the rural services, but make sure that the hospital that you're planning on going to knows what's coming to them and is ready, and that they have a heads up, because you're going to put them at a disadvantage and ultimately your patient at a disadvantage if you don't let them know.
And that brings up a good point about what we call passive rewarming versus active rewarming. Those are terms that we throw around in emergency medicine all the time. A lot of what's being described right now from the pre-hospital setting is an example of passive rewarming. I think of active rewarming as something that requires intervention aggressively or invasively. So putting chest tubes in to put hot water into the chest. Bladder lavage, like you said, rectal lavage. They can get very aggressive in terms of active rewarming in many cases. Another thing I was going to just point out with what Regan was saying and what you've alluded to as well, Phil, is that there are entire courses out there, and this is going to be a shameless plug to the University of North Dakota. the Advanced Wilderness Life Support class taught by Dr. John Solberg. He has instituted that for the last couple of years. If any of my medics or EMTs out there want to get some more hands-on, it is a great course to get your beak wet when it comes to managing and austere medicine. But that's one of the points that we make in AWLS, is that you don't need $1 million equipment to make a patient survive. Like, the important thing is to identify the things that are going to kill the patient or keep them dead and intervene as quickly as you can. And we've already kind of listed everything that would be in that training: getting the wet clothes off, getting them as warm as possible, trying to keep them from losing heat. Those are the core tenets from an AWLS perspective until we can get them to definitive care. So Regan has been slaving away as always, getting our protocols all bright and shiny. Let's talk a little bit about what it looks like for our shop in particular with how we manage hypothermia. Obviously, this is not a one size fits all. This just facilitates more discussion about some of the thought processes, some of the things that I want my medics and what I want some of my EMTs to look for when they're on a scene.
So our hypothermia protocol is slightly different than the case that we presented today because it is just talking about patients that are cold. It is not talking about patients that are cold and pulseless. So kind of just focusing in on just that hypothermia aspect. Like we've talked about, the first thing in the protocol is remove the patient from the cold environment. You want to prevent that further heat loss. Get them into the ambulance, get those cold clothing off of them, get anything that's wet off of them. And while you're doing that, try to avoid excessively manipulating them. And while I was going through these protocols, there's some instances where you would see some of the older EMS protocols saying like massaging the extremities or something to like warm them up. We want to avoid that. That is excessive manipulation. It might feel like it's helping, but one of the things within hypothermia is if you can't properly rewarm, it's not helpful to rewarm a little and then to go back cold. The changes in the vasculature with that vasoconstriction and kind of opening back up and then they get cold again, just not healthy for that overall outlook of any of those extremities.
And jumping in on that really quick too, think about this from a cellular structure as well, right? If we have a cellular structure, like we'll just say like a simple square cell that is now frozen like a block of ice, and we start to rewarm it a little bit and we start to manipulate and move it, you are now effectively destroying some cells. They're not all going to be completely thawed out. You risk these cells shattering and then creating further debris and further trauma to the patient. So if we keep rewarming, freezing, that's more and more trauma to the body. And as we've talked about in other stuff, it's going to break down muscle tissue. You're going to start releasing potassium. You're going to start releasing a lot of other things into the body that me as the receiving physician will have to then try to stabilize in addition to what's going on for the patient. There's a method to the madness. And so I always like to take a step back and say, so why don't we do it? And in this case is you don't want to cause excessive debris to start building up because you're freezing, thawing. Once we're in a definitive place where we could potentially do some of that stuff and we know they're going to keep thawing, then we can talk about it. But even in a level 1 trauma facility, we're not actively rubbing people's hands and feet. That's a no-no.
Along those same lines, we don't want the patient to be exerting themselves. If our patient is awake, cooperative, alert there, we don't want them up running around thinking they're going to help themselves get warmed back up. We continue with that nice covering up with blankets, using those heating packs, keeping them nice and calm to kind of reduce that extra damage that could occur with it. The other thing is we want to avoid warm beverages, caffeine, stimulants, things like that. If a patient is able to take something by mouth, again, in this case, our patient is down. We're not worried about this, but in some of these times, the patients are cold, but they are able to talk with us. We want to protect that airway. We want to focus on getting them a little bit warmer before we're like, hey, just chug some hot chocolate. You'll be okay. We'll pause that. We'll wait till we get to the hospital and warm up a little bit more before we're thinking about, eating or anything. The other thing that I have within this protocol, and it's slightly just different, but the pathophys kind of goes along with it, is like a true frostbite injury. These should not be thawed in the field. And this goes along with not manipulating, not warming them because you can't keep that temperature constantly rising. This is a little bit different than hyperthermia, like we've talked about previously with like the ice bath dunking or putting them in the body bag with the cool water. We don't want to just dunk our hypothermic patients in like a hot tub and think that we've fixed the problem because again, if they can't keep that temperature up, we're just going to cause more damage by them going back down to that colder temperature. So not thawing in the field, just keeping it as warm as you can with those blankets, keeping wet things off of it and getting them into that definitive treatment. And of course, like with any protocol, documenting as much as we can, getting a temperature if you're able to, marking the time of exposure, when they got out of there, when they were in there, how long it's been. These are all helpful things that can be given to the emergency department or to the hospital that you're bringing this patient into so that they can properly actively rewarm this patient with as much information as possible.
So we're going to go back into the field now. Let's say that after getting your CPR in progress, patients got their eye gel in place, you've got their wet clothes off, you've got the warm blankets, we've got some warm fluids sitting in the warmer that you've got going. You hop in the ambulance, and fortunately, it's like a 5 or 10 minute drive, and you get that patient into the emergency department. Let's talk a little bit about what that handoff might look like, or how you would envision being involved in the care of this patient in a rural emergency department. Let's say, for the sake of argument, it's the middle of the day, so people are there. There's the physician in the room, you've got the charge nurse, you've got 2 other nurses readily available. And as a matter of fact, outreach is open right now. So there's some surgical nurses that are also in the vicinity that can help you. Talk to me about what that would look like once you're in the EMS garage doors, backing up into the rig, and tell me how you're going to make that transition. Let's say, like, for the time being, that the patient is still in a unshockable rhythm and you're still doing CPR. Let's walk through the next steps.
For me, right off the bat, I want to make sure, and generally I'll know when I'm getting close to the hospital, I start gathering up all of my information. What's my latest set of vitals, if I have any? What am I going to start with in terms of whatever history of the event that I have and whatever other information I was able to collect on scene? And one of the most important things is time, right? So how long have we been doing this? When did we get on scene? How long has this person been down? All of these are questions that the receiving team are going to want to know. So make sure that you're starting to gather up, and these more complicated and longer transport type scenarios. That's when it's so critical to have a pen and a piece of paper. Write down what is happening so you don't forget a critical piece of information. I love making sure that I have my latest set of vitals, some times. In the middle of a cardiac arrest, time gets away from you. We stare at clocks and watches and making sure that we're keeping up on time, because 2 minutes will go by. You won't even realize what's happened. So you, as the person in charge of this run or one of the people running this call, you want to make sure that you're always aware of what you're doing and how much time it's taken. I've now responded to this scene. I have an approximate age of this person. What happened when we got there? Were they fully submerged? Do we think that this was a drowning and hypothermic event? How long have we been doing CPR? What interventions have we been able to do, particularly in terms of access? So IV access, if you're an ALS crew, or airway, if you're a BLS crew and you're able to do that stuff. And what have we done in terms of active rewarming? And if possible, this is an extra because sometimes we're moving fairly quickly, were we able to gather any sort of past medical history? Because remember, although in this case, we're pretty sure the ice just broke and then the whole thing went in there and they did too. But in some cases, we might be in a scenario where a cardiac event preceded them falling through ice somewhere, or a traumatic event preceded them falling through the ice somewhere. Branch fell, hit him on the head, then he fell through the ice. That's a different scenario, right? Cardiac event occurred, and he slipped and fell, and then he went off of the dock at the end of the thawing lake and then into the water. So all of these things, if you can suss that out, if you can sort of bring that out in the details, those things can be very helpful in terms of handing over care. And then I want to make sure that when I'm handing over care, and I've harped on this before, they're ready to receive it, right? I don't want to start talking in the middle of 50 people. Well, it probably won't be 50 people for you guys, but I don't want to talk while there's a room full of people trying to get all their stuff ready. I do want them to give me that second so that everybody can hear it and all the critical information I have, and make sure that if you're not getting it, command that attention. Don't be afraid to advocate for your patient. Make sure, hey, folks, I got information for you. Are we ready? And make sure that you identify who you need to give that report to. That's critical. A lot of times, there's a lot of people moving around the room, and it can be hard to tell who your charge nurse is, who's the nurse for this patient, who the attending physician is, who is actually the person that needs to receive the most critical information, because they're going to be making decisions going on as you transfer care. So those are the things that are sort of in my mind as I'm transferring care.
And I would say, if this is me receiving this, Phil, and I think that there's some similarity, but there's also some difference in practice, is that this is one of those situations for me personally that we're going to be doing a modified report, meaning this guy's currently got like a Lucas on him. We're actively doing CPR, so we need to get that guy transferred from point A to point B onto the bed. Let the nurses do their thing, but I think this is the most important thing. I want quiet. I mean, I know that people need to communicate a little bit, but what I envision happening is once we've got the patient transitioned over, we've got the iGel in place, we are not touching it because let's say for the sake of argument that SATs are looking okay as far as that goes. As we're currently getting lines, doing other stuff, if there's any wet stuff, getting it out of there, that is when I need Phil taking command of the room and just talking, not yelling, not shouting, but talking in a tone that is going to take command of the room so that the people that need to listen can listen. Ideally, I want my nurses and everyone in the room to listen, but the important ones are myself, probably the charge nurse, and the one in the corner who's writing on the whiteboard, writing all the details. Like that's the big picture job. And that's why I call it like a modified approach, is that in this one particular scenario, he is currently pulseless. So we need to make sure that we're continuing to intervene. We cannot pause resuscitative efforts in this case. But as Phil alluded to, he has pertinent information that's going to help me drive what the next steps are. And somewhere in there, we need to figure out a core temperature. I would say that for the purposes of my smaller services, a core temperature is not something I'm worried about, especially in this setting. Like get that patient to the ER. We will flip them at some point, probably during a pulse check, quickly check the backside, and then move on. Regan, anything else you wanted to add from your side of things, especially as you're about to enter into doctorhood?
Just from my minimal experience kind of in the rural side of things, something that I've really thought was very helpful from the EMS crews. And of course, if there is not enough crews in the service area and you need to get back en route, absolutely go right ahead. But in some of these cases and in these kind of critical access hospitals, it doesn't hurt just to be like, can I help with anything? Like it might just be like, do you need me to try to get one more IV in here? Or do you need me to assist while you intubate? Like EMS personnel are talented individuals who have good skills that still translate when it comes into the emergency department. And in a lot of these rural settings, it helps to have some extra set of hands. So just like Phil was saying, do not be afraid to advocate and say, hey, I have information. Are you ready to listen? Don't be afraid to be like, anything else I can help with, any last little things that you need a hand with before we go back into the field.
And let's change the scenario. What if this is 2 a.m? Someone just happened to see this thing go through. Now, all of a sudden, I've got one charge nurse, maybe one nurse in the hospital. There's 2 people. That's it. You might be able to call for help if there's enough time to get people out of bed so they can drive in and help you. You might be able to call the CRNA and whatever. But it's really nice to have my EMS crew stay. And like if I need to get an airway or if I need them to get a line in, or in one instance, one of my paramedics stayed and wrote on the board for them. So that was one less person distracted from doing all the documentation. They just sat down and they just started writing on their notepad what the steps were so that was one less person that could then give patient care in the hospital setting. We really need to get away from that idea, especially in the rural settings, especially in the incredibly rural settings, like the towns of like 500, 750, et cetera. Every single body helps, right? Like if you've got someone with medical knowledge that's done the training, that is comfortable doing this stuff, that ambulance team should not leave because they're probably going to be the one that transport this patient on to the next facility unless there's a helicopter or something inbound. So we'll say that you gave excellent report. You stayed by the bedside and got some more IVs in. Regan got her point of care ultrasound out and was checking pulses that way instead of feeling for it because the sensitivity is like 40 to 60% when you're feeling a pulse. I bet it's even more so when it's cold. You get that temp up into like the 92, 93 degree Fahrenheit range. You start to see some meaningful activity on the monitor. Respirations become more spontaneous and you get ROSC. And what an amazing feeling that is. An important sidebar, there are case reports out there for people underwater freezing for extended periods of time and having good neurologic outcomes. So do not let the extrication time prevent you from providing quality care. There is still a possibility, I can't give you percentages because they're case reports, that person could still have a meaningful outcome. This is where that whole discussion came into play over a number of years, which has been disputed again, is cooling patients down because for some reason patients seem to be able to do well for longer periods of time under cold conditions. Granted, that part has been debunked more in the coronary ACS STEMI field, but in the context of patients that are submerged, patients not dead until they're warm and dead. And sometimes, even though you think that, man, they had CPR for 90 minutes and extrication time was delayed, you won't know until you know. So we've walked through a little bit of a rather mean hypothermia case. We talked about the pathophys, the things to identify, the things that we can reverse. talked a little bit about what a basic hypothermia protocol might look like. And obviously there's nuances, and it also depends on what equipment you have and all that good stuff. And we talked a little bit more about interventions once we get the patient from point A to point B. Anything else? Any high points, any takeaway points? If you had to give like 3 highlights from both of you, what are your 3 big things that you would want your fellow medics, EMTs to take away from this?
Yeah, takeaway points on my end. Make sure that you're utilizing the resources you have on scene. And that includes making sure that once you identify what you're looking at, call for what you need and get those balls rolling. Okay. You're going to need hands and you're going to need help. And don't be afraid to make use of the people that are around. You got an able-bodied person that can walk back to your rig and grab something. You have able-bodied people near you that may want to help but are unsure of how. Make sure you're controlling your scene. So there's one. All those things kind of wrapped up into your scene control. 2, prioritize your patient. Your interventions, for instance, in the case of someone who is pulsus and apneic, focus on good, high-quality compressions is key. Don't let things distract you that are sort of less importance or maybe downstream interventions. You want to make sure that your interventions that you are using to help save this person are the ones that really are going to make a difference. And you want to make sure that you pay attention to those things. And then the third thing is people are going to be looking at you for a sense of calm and control. If you run around and if you start yelling, and if you start moving quicker than your mind can keep up with, and if you start looking like you're panicking, expect that will have a huge impact on how your scene is going to be managed. The calmer you are, the more in control you are, the better, and the better outcome for the patient. And the way you get there, particularly if you're listening to this podcast and you're like, man, I don't know what I would do. I don't know how I would react in these situations. I always tell people, please, please, please don't underestimate the value of walking through a scenario mentally in your mind so that you can sort of step by step go, okay, I would do this. I would grab this bag. I would walk over here. I would make sure I have my radio. I would make sure that I'm communicating with my partner. Let's talk to the officer of the engine. Let's talk to the senior officer from the police side or whoever, and walk through those scenarios mentally and do it a few times. Because from the emergency management sort of research, we know this sort of cognitive walking through of scenarios gives your mind a file to pull from in the off chance that you're in this situation that even though you've never actually in person been involved in or seen it, you actually have now a file of at least a starting reference point instead of your mind looking for a file and opens a drawer and there's nothing there because you've never even thought about walking through a scenario like this mentally. So don't underestimate the value of doing those things. And those would be my takeaways on this particular scenario.
So my takeaways from this scenario are applicable to kind of all of them. This is something that I've been learning in this kind of last little year of med school and trying to figure out how do you become like a leader of your team. And I think it's really applicable to when you get out in the field and it's you and your partner, you and the police, you and the fire crews. These are like my 3 little checkpoints for all of these things is first, have everyone be prepared. And when you're out in the field, you get that dispatch, you get that call. You should be talking with your partner about what you might expect, what you're planning on doing, what happens if we sense this scenario, what happens if it goes this way. That communication starts immediately after getting that call. And hopefully in a case like this, you're getting this dispatch that we have an ice house that went down. There's probably a person in here. Your brain has now taken that file that Phil said you've prepared and you're starting to talk about it with your partner. When you're getting onto that scene, my second takeaway point here is keeping everyone aware. Your brain is probably running so fast and there's so many things going through your head, but no one can read your mind. You got to make sure that you are talking with your team, even if it feels like you're just repeating some information. Staying vocal during these scenarios is very helpful so that everybody knows what's going on, what some next steps are, and where we're at with our whole scenario. So do not be afraid to just repeat, we've had CPR going for this amount of time. Have we cut off all of the clothes? Good. And just checking all of these things so that everyone remains on the same page. And then my third takeaway point, which these aren't in priority because I feel like this should be probably first priority, is making sure that you keep everybody safe. If this ice house has fallen through the ice, you could easily fall through this ice. Just remember that a lot of these emergency scenarios are not the safest scenarios to be in, and you do not want to create more patients by putting yourself, your partner, anyone on your crew in trouble. So just always keeping that in your mind when you're going to a scene, when you're on a scene, when you're leaving a scene, just kind of mentally checking, am I safe? Is my partner safe? Is this crew safe?
And for those of you out there that want to learn a little bit more about austere stuff and things like hypothermia and people that are lost in the woods or that kind of stuff, Advanced Wilderness Life Support might be a great course for you to take just to kind of get a better idea of how you might manage this stuff in the austere environment. We actually have that course getting taught at UND right now that's predominantly for med students, but if we've got open spaces, we make that open to people in the community. We've had some medics go through it. We've had some of our professors go through it. And I know that UND is not the only place that has that, but if it's something that's interesting to you, check it out. Go check out the AWLS website and just see if there's any classes near you. I cannot recommend that class enough. I think it's a great primer for some of the stuff that we talked about today and great practice for how to manage patients in that type of scenario.
All right, everybody. So that was our discussion on hypothermia. We hope you enjoyed it. As always, please make sure to reach out to us if you have anything else you'd like to hear us talk about. We appreciate you staying with us for this episode. We know that it was kind of off the cuff, but I like it. And if you like it, let us know. And if you have any ideas for topics you'd like us to talk about in the future, again, we are always ready to hear them. So thanks a bunch.
May your mayhem be well controlled, full of teachable moments, but also provide you with the opportunities to provide your patients with the best care possible.